The fourth question, there are some hospitals with no EEG machines. And as discussed, continuous EEG can help us guide for the treatment and diagnosis. In the absence of the EEG, would it be best to treat the seizures clinically?
Well, we always treat the seizures clinically. So if you have an EEG and the EEG is abnormal, but your patient has no clinical seizures or nothing that would tell you that would make you suspect that there's something wrong, then we don't treat. Now, on the other hand, if you have no EEG machine, the most important thing really is to get a very, very good history. And if according to your history, you think na mukhang seizure talaga yon, then yes, you can start treatment even without the EEG. Nowadays, we all have cameras on our phones, di ba? So what I tell my patients, you take a video. Take a video para I can see what it really looks like. Because sometimes when you see it, you can say na, parang hindi naman seizure yan. Or, yeah, you're right, that's probably a seizure. There will be some patients where you're really not going to be sure and you're really going to need an EEG. Now, I'm supposing that maybe this is for the ICU setting that you're asking that about, in which case it will be a little bit more difficult because in the ICU setting, a lot of the seizures can be focal seizures, very, very, very mild seizures with very, very minimal manifestations. Like maybe they might just have a little bit of nystagmus with the eyes twitching to one side, yun na yung seizure niya. Or maybe they might just lip smack like that, and then yun na yung seizure niya. So sometimes it can be difficult in the ICU to differentiate if it is a seizure or not. Especially since when you have patients, for example, who are a little tulula in the ICU, it can be a seizure, but then it can also be encephalopathy. Ba?
So best to video and show to the neurologist. This next question is to Dr. Risa Franks. In low-resource settings, are we allowed to initiate dual platelet therapy without cranial CT scan, provided that clinically the patient is manifesting with symptoms of CVD infarct?
That's a very good question. No? It's a bit difficult because sometimes, we know that they present the same way with focal symptoms for both for infarcts and for hemorrhages. And sometimes even if the hemorrhage is small, you can't see it. So, but you still need actually a CT scan. And if we start dual therapy, especially, this might expand the hemorrhage that's already there. So my answer to that would really be probably no, because of the fact that we can't really tell. No, I know it's difficult. But the harm that may be caused by giving dual, not knowing if it's a hemorrhage or not, might be bad or hard for the patient. So I think you have to be careful with that.
And then I think we can combine questions 2 and 3. In the SSP guideline, we give aspirin 160 milligrams for 14 days and then 80 milligrams once a day after. And then how long do you give the antiplatelets?
Okay. So yes. Yeah, for the SSP guidelines, that those was before, I believe, when point trial came out, no, and the point trial and chance were worldwide. Most likely we will have to revise that. But in terms, to answer your question about how long we would give the antiplatelets, usually it's for a lifetime already, or indefinitely would be the answer, because your risk of having another stroke, if you've already had one, is high if you don't have any of the antiplatelet agents. So what we tell our patients is, it's indefinite. We don't have a stop time for the antiplatelet agent. So if you start also with dual, you end up taking out one, and then you're left with one antiplatelet agent.
moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share, every second counts. Live integrated tele-ultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated tele-ultrasound collaborative platform. Philips Lumify. Integrated tele-ultrasound powered by React's collaborative platform. Innovation and you, Philips.
The fourth question, also to Dr. Risa Franks. Why is it not good to lower the BP drastically right away, but better to lower it gradually?
You know, one of the things we face when we see patients in the ER is we don't really know what their baseline blood pressure is. And interestingly, they deny being hypertensive, but upon workup, we notice that they really are living on a higher blood pressure. So in terms of what we call autoregulation, if we suddenly lower it to what they were probably living at, then you may be putting them at risk for expanding the stroke. So that is why we don't lower it that quickly. Also, like I mentioned, if you lower it quite quickly in the very acute setting, then you're already also decreasing the amount of perfusion in the area that you want to salvage. So actually, we don't even lower it at that time. In fact, we try to continue with hypertension so that the area that could be salvaged will be perfused adequately, and the area with the irreversible infarct already or the completed stroke would be much smaller. In terms of timing, they say about 15% of what they come in with. And that is so that they don't suddenly lose perfusion in an area where they normally have good blood pressure.
And this is the last question in the Q&A box for Dr. Risa Franks. What causes hyperthermia in stroke patients if it is not caused by any underlying infection?
So we've seen patients who come in, yes, you're right, it's more of a reactive cause, an inflammatory process. And interestingly, when a fever is noted upon admission, automatically you go into your septic mode looking for the cause, and you don't find any. And then you see that even with a white count, it might be a little elevated. It usually is due to a reactive cause. So, but at the same time, you still want to lower that. It could also be central. That is why it is not due to an infectious source. But still, because of the hypothalamic process, it could still be a bad thing to have a high temperature.
Okay, I think that ends our Q&A. There are no more questions.